Hello there and welcome back to Under the Dome from Town Meeting TV. My name's Bobby Lucier. We've made it past the end of adjournment for this year's session, and there's a lot that has been accomplished and a lot that's a bit uncertain as the governor is deciding what to pass and what to veto here. So today we're talking about healthcare and some of the work that's been done in the Vermont legislature on healthcare. We have 2 episodes on healthcare today. The first is looking at the House side of things, and we're joined by House Representatives Ray Garofano, Representative Daisy Berbecco, and Representative Alyssa Black. Thank you all so much for joining us.
Thank you for having us.
Great. So let's start with something that seems likely to pass, I think. I'll back up and ask for just a brief introduction from each of you. If you could share what committee you serve on, what district you represent, and how long you've been serving. And maybe we can start with you, Representative Garofano.
Sure, nice to see you, Bobby. I'm Representative Ray Garofano. I serve in Essex. I'm from Essex, and I serve Chittenden 23, which is Essex and Essex Junction, and I serve on the Human Services Committee, and I was appointed to the House in 2022, so this is my 2nd term.
Great, awesome, thanks so much. Representative Berbecco.
Daisy Berbecco, and I represent Winooski, and I'm on the House Healthcare Committee. This was my 1st term.
Nice, congratulations.
Thanks.
And I'm Representative Alyssa Black. I live in Essex. I serve Chittenden 24, which is sort of the northern part of Essex. I always say if it's a dirt road, I represent it in Essex. This is my 2nd term, just finishing out my 2nd term, and I am on House Healthcare along with Representative Berbecco.
Awesome, great. Thank you so much, and congrats to the 3 of you on making it to the end of the session. Any big picture reflections, thoughts? I know this was a tricky session compared to other recent sessions where there was a lot of federal funding available. This was a tougher one. Any reflections or thoughts on the session as a whole?
I think, and maybe I speak for Representative Garofano at the same time, because we both came in during the pandemic. So we're sort of used to working under the COVID relief money, and I think this year was a big wake-up call to some of us newer members because most of that federal funding has dried up, and it was a very, very difficult budget year, and that made things challenging. So
certainly. Anything to add, big picture?
I would add that I think I just feel so lucky to have landed where I did. Number 1, representing Winooski, and number 2, with the committee that I ended up on. The healthcare committee was just amazing. I think, like Alyssa said, when there's fewer resources, you have to really be collaborative and creative, and I felt like we had an extraordinary team to do that with.
Sure. I'll just say that with all the challenges, I feel like we still got a lot done, and that feels really rewarding. And I feel like we had an opportunity to kind of set up some future work, which is really important on education finance and on future healthcare, housing reform and development. So I think we're setting ourselves up in a good place, even though we weren't able to kind of implement a lot of the things that were kind of on deck for us this session. I think we're nicely set up for future.
Reminding you all tuning in at home that if you're watching this program live, you can call in at 802-862-3966 with your questions for your representatives, and we will pass them along to you as best we can. But right now, we'll start with taking a look at a bill related to PFAS and the effects that it has on our health, and how it sounds like this bill, maybe I'll let you talk about it, Representative Garofano. I think it's S25, yeah?
Sure. S25, and I'm not going to try to pronounce the 2 chemicals that are in the title of the bill. We had, luckily, Representative Whitman, who has done a lot of research on this topic, who was our committee expert on the bill. But PFAS basically was continuation of work that had begun in 2021 around these forever chemicals. And these forever chemicals basically, they don't break down ever. So, and they're used in a lot of products that we use daily, shampoos, lotions, things we wear, clothes that's waterproof, rain gear, in textiles, waterproof fabric for sofas. So they're in our everyday lives. And there's been a lot of research recently that they're very harmful to our health. And the work that we had done needed more continuation. So the Senate started this bill last year, and we build on it this year. And basically, it bans these chemicals in household products, in personal care products, in menstrual care products, and in artificial turf. And we built on a work that's being done in other larger states, such as California and Washington and Maryland. And it basically regulates what manufacturers can intentionally add. So they are not allowed to because PFAS does exist in the natural elements. So it's regulating what manufacturers intentionally add. And we worked with a lot of stakeholders. This was a really complicated bill that we worked on and took a lot of testimony on from industry and advocates and experts. And we landed in a really good place with effective dates starting in 2026 all the way through 2028, where manufacturers who are already signaling that they're getting away from using these chemicals will have time to adjust to the laws, and knowing that a state such as California has passed very similar legislation allows manufacturers, especially Vermont manufacturers, to kind of be in line with what California is going to do and what is expected of them to do in Vermont in about 2 years.
Right. What are they used for? Why do manufacturers use these chemicals?
So they're like a binding material, and they're waterproof. So the way I kind of think about it is if you use waterproof mascara or lipstick that's long lasting, which I use all these things. So it's been really, I wasn't there in 2021 when they did this. And I think in 2021, one of the aha moments was that they're used in nonstick cookware. So imagine you're thinking, you're learning, you're sitting in a committee room learning about, these are everyday products that are used. So their binding characteristics help manufacturing in like chapsticks and mascara and lotions, so they don't like wash off, basically. So that's generally what they're used for.
Right. Does this mean that should folks expect many products to kind of no longer be on the shelves in a few years that they're used to seeing?
So I think we heard from industry that a lot of manufacturers are already finding alternatives. So things aren't going to come off the shelf necessarily. It's that they're going to be manufactured with healthier alternatives that are not harmful to our health. And like I said, knowing that other states and the EU have already moved to this direction like several years ago, manufacturers are already kind of working to find healthy alternatives that are more natural and not harmful for us.
That's great. Anything to add from either of you on this bill, the PFAS ban?
It was very important to Winooski. I know a lot of folks, I heard from a lot of folks in my district about this, and I just applaud the work of Ray and her committee on addressing it, and I'm happy with where it landed.
Yeah, and I heard from an awful lot of constituents on this in support of it, and I'm grateful to the Human Services Committee and Representative Whitman for being able to pronounce it.
Yes.
So I thought about trying to at the beginning. You know what?
We'll just go with PFAS.
PFAS. That's great. Okay. Well, let's move on now to, you mentioned, the Human Services Committee is where Representative Garofano serves, and then the Healthcare Committee is where the two of you serve. Let's start with, in the Healthcare Committee, prior authorization reform. Representative Black, can you talk a little bit about that?
Yeah, so we passed H766, which is an act relating to prior authorization, step therapy, and also some claims edits pieces. So I had said at the beginning that one of the things that became very apparent at the beginning of this year was, that the budget was going to be tight. And I think we looked, particularly in our committee, what levers can we move, what other things that we can take up that will not cost the state any money and ultimately will lead to better efficiencies. So we worked a lot on policy, and this is one of these policies. So we have been in the legislature, and I'm very grateful because there were tons of study groups and reports and working groups, analyses over the last 15 years on how to reduce provider burden, administrative provider burden in our healthcare system. And a lot of work has been done around prior authorizations. There have been instances that have been put in place to try to limit the amount, and yet, unfortunately, what we've seen through the years is that they just keep increasing. And we took testimony from providers so the Green Mountain Care Board has a primary care advisory group. That group, their number one priority is reducing prior authorizations. In every survey of physicians, things that are leading to burnout, the number one thing is administrative burden. What has essentially happened over the years is that the administration that insurers, payers, insurance companies used to do has now been downloaded onto the providers to do. And we had testimony, there are providers that are spending 2 to 4 hours a day working on prior authorizations, claims issues, denials. That is 2 to 4 hours a day that you are not seeing patients. And we have a critical primary care shortage in this state. And so anything we can do to alleviate burden on them, then we were going to work on that. So what 766 does is it'll start first is step therapy. Step therapy is, you might know if you've ever been on a medication that your doctor has prescribed, and yet your insurance company says, no, you need to try this one first. And you need to try and fail on that one. And then they can send you to another one, and you have to try and fail on that one. And you have to go through these steps to essentially get to the medication that your provider wanted to prescribe to you in the first place. And we have put some guardrails around that process. We still have step therapy, but what we do have is we have eliminated the insurers making you jump through hoops when your provider can give clinical justification for why you should not be on those medications that they know are not going to work on you. And so that will eliminate that piece where your provider can go directly to, here's what I'm prescribing and here's why I'm prescribing it and here's why I'm not prescribing these other things. And the insurers have to go by that. It's giving providers the discretion to practice medicine the best way they know how. And that's what they are clinically trained to do. There are other pieces around prior authorizations regarding the time frame that insurers have to respond to prior authorization requests. Urgent requests have to be within 24 hours. All other requests have to be adjudicated within 48 hours. There are pieces around if you change insurers, how long they have to cover the medication that you're currently on before they can make you go through prior authorization hoops for your new insurer. There's stipulations around people who are on long-term chronic medications that require prior authorization. Currently, right now, you have to get a prior authorization every single year. That's even if you've been on a drug for 10, 15, 20 years and it works. And we've put some guardrails around that to where it's only 5 years now.
Can I ask sorry, go ahead.
No,
if you have
and
one more thing.
the biggest piece though is what we've done is we have eliminated the requirement for primary care providers to do prior authorizations other than prescription drugs. We cannot do it for prescription drugs, unfortunately, because every insurer has different formularies that they're working off of, and for out-of-network services. So your primary care provider, the most cost-effective care that is delivered, we have eliminated prior authorization for them. And that's pretty big. And if you think about the amount of the market that we control, I mean, because there is a lot of the healthcare market that we have no control over. But it's about 25% that we do have in our ability to put control on. And when you combine that with over 25% of Vermonters are on Vermont Medicaid, which has very few prior authorization requirements, and another 25% are on Medicare, and Medicare has no prior authorization requirements, you're talking about 70 to 75% of the market, and that is a huge relief on providers.
Yeah, absolutely.
So
there have been some concerns about this bill that it might raise insurance premiums. How do you respond to those?
we
concerns?
took extensive testimony from all the insurers. We were given many, many numbers over the course of testimony, which was 4 to 5 months. We kept asking them to back up their claims, and we really could never get straight answers backing up their claims. And one thing I really want to point out, particularly when it comes to payers, is, you know, both of our payers that are in the exchange, they are both nonprofits. However, they farm out their prescription benefits through pharmacy benefit managers, PBMs, their prior authorization requirements. They have third-party vendors that do all of these things. So the data that's coming in, and by the way, those third-party vendors, they are for-profit, and they are big for-profits. I mean, this is a industry that's hundreds of billions of dollars in the US. The information that the payers were giving back to us on projected cost increase were basically numbers that were given to them by their third-party vendor, basically saying, here's how many prior auths we got, here are the ones we denied, let's put a dollar figure on the number we denied, which is difficult to do because there is no claim, so you don't really have a dollar figure, and every provider has different allowed amounts. That information is coming from those third-party vendors. Those are for-profit vendors. We kept getting return on investment from our payers. We pay millions of dollars to these companies, and we think we're getting a return on investment in denials.
Right.
And that information is coming from those third-party vendors that are for-profits.
Yeah. Representative Berbecco, your thoughts or work on this bill? You want to share your perspective?
I think one thing that Representative Black said I'd pick up on is that this was an effort to really look at where we can impact the state budget overall, in addition to addressing provider burden, which I care deeply about. But we also know that, you know, one of the most expensive pieces of our education budget and is salaries and benefits. And so this falls under, you know, something that we did creatively to really impact and reduce the cost of health insurance for teachers and thus the Ed Fund. So when I said creative strategies earlier, this was definitely one of them.
And I wanted to add to that, you know, we in our committee and across the state, we have to look at the healthcare system as a whole. And, you know, payers spend about 7 to 8% of premiums that they receive on administration. Well, hospitals also have to submit their rates to the Green Mountain Care Board. And hospitals, their administration is upwards of 20 to 25% of their dollars. And So when we talk about, maybe the payer is saving a little money by denying care, we have to look at the fact that our hospital systems are spending almost a quarter of their budgets on administration to be able to administer that. So, it's about bringing the costs down on one end, which might increase a tiny bit on the other end, but we're really eliminating things that don't need to be done and things that suck money out of our healthcare system, which don't provide healthcare. So on the whole, we think it will be a savings to the system as a whole.
I think the last thing I'd add is just that I don't remember what the floor vote was on this when it came to the chamber, but there was some extraordinary support, and just it really resonated with a lot of different members. A lot of people shared personal stories, especially around the step therapy. So I think this was probably one of our most important bills that we passed this session.
Has the governor signed this bill yet, do you know?
He has not. I'm not sure it has gone to his desk yet.
Okay.
It's in the queue of bills to go to his desk.
Okay. Has it passed the Senate?
Passed the Senate and the House, yes.
Okay, gotcha. Maybe we'll move on now to talk a little bit about mental health care and the mental health crisis. And Representative Rebecca, I know you've worked on this issue a little bit. Can you speak about the work that you've done on mental health this session?
Yeah, I think hopefully one of the bigger impacts that we've had, which is one, responsive to what we've heard from a lot of people in the field, and then also to kind of alleviate some workflow issues, is we passed a peer certification bill. So what that does is it really formalizes some of the work that people with mental health, lived experience of mental health, are doing in the community to really support folks who are actually going through some mental health challenge themselves, and kind of help them navigate the system, because unfortunately it's not easy to do. So by certifying them, we can standardize what some of our training requirements are and certification, and that enables us to draw down federal money to pay for those roles. So we're not just doing it for mental health providers or peer workers, peer support specialists, sorry, but also for folks that do the same to assist people in recovery. So I think that's one that I'm really proud of, and I'm really hopeful will improve not just the workforce and the pressures there with bottlenecks and access, but really the quality of what we get when we go to seek mental health supports. There's tons of data from national studies that have been done since we are one of the last. I think South Dakota is going to be the last state to certify peer health workers or peer support specialists. So there was tons of data to inform that this is something we need to do. And on top of that, the peer community in Vermont is very active. And, I'm proud that we allowed them the space to create this. And we really listened to them and worked collaboratively with the Senate to really get this passed. And Department of Mental Health and Department of Health were great partners in this. And now the next step is for the Office of Professional Regulation, OPR, to really do the work to make it official.
When you say peer, what do you mean by peer in this context?
So for mental health, it's someone who has gone through a mental health challenge and navigated the system, so they identify as someone who has lived experience of that.
And then these are paid positions. Like, what does a peer support specialist position look like?
Well, it can look like a lot of things. I mean, the Department of Mental Health has a 10-year plan, the Vision 2030 plan, and one of their 9 goals is to have peer support at every level of care. So right now, where these folks are working is in, Howard Center has peer support specialists, and they pay them, but Howard Center is not able to draw down federal reimbursement for that work.
I see. Okay. Yeah. That's really exciting. Anything else you want to add about mental health in this session that you've worked on? I know this is related, of course, to overdose prevention centers, which we'll get to in a minute,
right.
But I wanted to just hold some space for any other mental health work. There are a lot of different aspects of that.
Yeah, I feel like there's never enough mental health work done. This year we provided a 3% rate increase to staff at the designated agencies, which are the agencies that are that we can impact the budget of and salaries of. So that's a good thing, but again, it wasn't as much as anybody would like it to be. I think there's severe underfunding of the mental health system in general, and especially for salaries. But what we did do is, again, try to kind of address some of the bottlenecks and listen to where the pressure points are in the system. And one is to finally address the issue that we don't have a place for folks who have a severe mental illness and are justice involved. And there's been a lot of work done in our state on this over the last decade. And we came up with a really collaborative solution. We worked with folks on Ray's Committee on Human Services, because this also happens to folks who have intellectual or developmental disabilities. And they have, primary healthcare needs, but they're also justice involved. And so we want to be sure that they're in a space that they're getting the care that they need, and also we're able to address the justice issues. So we, rather than standing up a new facility, which would be building and, even more time, we have modified some of the policies for admittance into an existing facility, Riverside Therapeutic Community Residence, which is in Essex. So we'll take some of those empty beds there and allow the different types of clinical supports that those folks need so that they can reside there while they're getting treatment.
Anything to add on mental health from Representative Black or Garofano?
I think we also did and maybe I'll let Daisy speak to this. I mean, one of the great things about having Daisy on House Healthcare is just her knowledge and breadth of the system of mental health care that we have in the state, and she has been just invaluable in that. So she really digs in deeply on these policies. We did do a smaller bill to update mental health response for municipalities, and to come up with sort of statewide guidelines that municipalities can follow when responding to mental health crises in their communities.
Right. So what do those guidelines look like?
So it actually enables a committee to do that.
Okay.
So we don't make the guidelines ourselves, but rather we create a pathway for the experts to do that. Okay. And I think this is something that allows us to kind of standardize and really have some clear expectations of what we can do to support people in municipalities that actually end up being kind of the front line of supporting folks and getting them to the right level of care. So I think this enables them to have a few more tools in their toolbox.
When you say municipalities, is this like situations where people are interacting with the police and need a different avenue for either treatment or services?
Yeah, EMS workers, police, everybody who's, city employee, municipal employees that are dealing with the general public.
Okay. Well, on a, I think, related note, maybe we'll move on now to H72, which is the bill to establish overdose prevention centers, or I guess just one overdose prevention center at this point, right?
Yeah.
Representative Garofano, can you tell us a little bit about this bill?
Sure. H72 will establish a pilot program. So it's important to note that this is a pilot program, and currently it's slated to be in the city of Burlington. And this is a really important tool in the toolbox for folks, responding to our opioid crisis. The center will provide harm reduction supplies, emergency medical services, a safe place for folks to use, and then most importantly, connection to services. And we have been working on this in our committee for several years, and the intent is to save lives. Short and simple. This center will save lives because studies have shown that when people use alone, they die. And that's what we're trying to prevent. This, I think, is the first year since I've been in the legislature that we have not broken a record in deaths in Vermont and to opioids. So that's great news, but the numbers are still frightening, the lives that are being lost. So It's also important to note that the center will be funded by the opioid settlement funds, so this is not state money that is going to this facility. We also have taken, with our colleagues in the Senate, just hours and hours and hours of testimony from experts, our own health department, physicians, places around the world that are, utilizing these types of tools. And the research and the experts say that it does not increase crime. It actually helps reduce crime in the area. It helps, the random needles that you see on different places. It really gives a safe space for folks who are really struggling with opioid addiction and substance use disorder to go and be safe, and it provides immunity to the people that work there and provide these services. I'll say that there was a big, huge stakeholder group from Burlington that from the previous mayor and the current mayor and the EMS fire department that is supportive and was engaged in the conversation. So we're excited to have that get to the finish line. It is not likely that the governor will sign this bill, so I think I'll have to wait till June.
Right. Yeah. Anything to add on this bill at this point?
I'm really excited about it. One reason is we know that folks who use a overdose prevention site, they have connection to care community, and so I think the more that we can interact with those folks and let them know that, recovery is possible and what to do if they're ready to look for that. And so I think just this being a resource opportunity is a really big highlight.
And I'm very excited about it also. As Ray said, people who use alone die, and this prevents deaths. And I know that it seems like it's impalatable to some people, but it's about nothing other than preventing death. And the more opportunities that you can give someone to eventually get to the point where they make the choice that they want to get into recovery, this is just another avenue of keeping touch with these people and just keeping people alive.
This, I think, is really a testament to the belief that every life is valuable, right? And I think that's what makes me proud, is that we were able to work collaboratively to really put that into action and provide this to folks. So we'll see how it goes.
Some other things I'll add that we worked on in our committee related to recovery and substance use disorder is that we also passed a recovery resident certification bill. And what those are, right now there's only 13 recovery residences in Vermont, and they're basically peer-supported houses where folks that are in recovery, especially in early recovery, can go and have a structured place with peer support around them. So this bill will it directs the health department to come up with regulations on what it is to certify these homes, because there are non-certified homes that operate in Vermont, but we want consistency and we want to encourage more recovery residences to exist. So folks that are coming out, for example, out of incarceration or in very early recovery and have no place to live, have a safe community to be in. So I'm really excited about that. And then additionally, I believe it's about $1.1 million was included in the budget. And I think this is opioid advisory or opioid settlement dollars that will go to establish some additional stabilization beds across Vermont. And that's for folks that are in very early recovery that have relapses, which is very normal and very common. So they're not again, put in a situation where they may not be able to live in their recovery home or where they are living currently because they don't want to destabilize their current living situation. But that gives them a place to go until they can, kind of get past that crisis point, and then they can return to their stable housing. So I think, we talk about tools in the toolbox. Like, we need to be, again, creative. We need to utilize the resources that we have. And, we haven't invested so much in a lot of these areas for a really long time. So I'm excited that these bills have made it through the finish line this year.
There are a couple questions I've heard around where and when just jumping back to the Overdose Prevention Center pilot, where and when that would be established specifically. I know in Burlington, but where in Burlington? Can you talk a little bit about the process that might be used to figure out where that location is?
I don't know the location. I don't know if Burlington has identified a location. That's going to be between the city council and the mayor.
Okay.
So, once the bill becomes effective, then it's kind of goes over to the local municipality, and we provide kind of the guidelines, and the health department will work with the municipality to identify the location and figure out the guidelines around operating.
Did you want to add
Can
something?
I ask Ray a question?
Sure.
Overdose Prevention Center, right? I also hear people want to call this a safe injection site. Can you tell us a little bit about what the discussions in your committee were around language and what's correct?
Yeah, I mean, I think we opted to go with Overdose Prevention Center because that's, you can call it many things, right? It could be a safe injection site, Overdose Prevention Center, and I think for us, it was more of a positive spin or positive language to call it Overdose Prevention Center, because that is literally what it's meant to do, is to prevent overdose and prevent death by overdose. So that's what we opted with. And I know last year, because this bill, I believe it started last year in our committee and went to the Senate and came back to us. And thankfully, our Senate colleagues agreed mainly with what we were doing and sent it back to us favorably with small amendments. But I don't know if there's a right answer, but we chose to go with overdose prevention because that's literally what it's meant to do, is to prevent overdoses.
I mean, personally, injecting drugs is never safe.
Right.
So
yeah.
I think Overdose Prevention Centers is, I appreciate it.
Yeah, I've heard a few, I think, supervised consumption centers and other.
Yeah.
Yeah.
I think in Canada they might call it that, but we took testimony on that last year and I don't remember. But Vancouver has several centers, and I do believe they call it supervised consumption center.
And it sounds like the governor has some concerns about this bill and has suggested maybe that the roughly $1 million needed to set up this facility, he claims would be better invested in other existing treatment programs. How do you all sort of respond to those concerns as they come up?
We need both. We need all. We need all the tools that we can get. I don't think it's one or the other. And I think this tool has proven that to be effective in other areas where it's used, and it's a pilot. We can see if it works. I think it's worth a shot given the number of deaths we've experienced in Vermont. Why not try something that research says it might work?
Does the vote that passed this bill, does it have, at least at the time that it passed, a veto-proof majority, or is
Don't remember, to be honest with you, Bobby. I don't remember what the numbers were, but it's also important to know that, like, when a vote is called, many members may be absent. It depends on the timing of if it's later at night, a lot of people go home. So I wouldn't, I think as a caucus, we kind of move bills that we know the caucus has broad support for. So I know the Democratic caucus and the Independent caucus has very strong support for this bill in the House and the Senate. So I'm excited to kind of come back in June. I mean, I hope the governor signs it. That would be ideal. But I hear that he has a lot of concerns, so I'm not holding my breath that he'll sign it.
Maybe we'll move on now to an effort in this session to expand Medicaid and Dr. Dinosaur. And this was a bill, it started as its own bill, and then it sounds like it was moved into the budget. Representative Black, could you speak a little bit? This started as H721, I think.
Yeah, so H721 started as a visionary bill around expanding Medicaid. One of the things that we know is going to happen, so under COVID, federal subsidies increased for people who purchase on the exchange, tax credits or subsidies. And they were expanded, up to very large amounts. Essentially what the federal government said was, we're going to make it so that you only have to pay a certain percentage of your income towards health insurance. So depending on how much you made, you'd get a better subsidy. That is going away. And we know it's going away. And I would say we're deeply concerned about people who are currently on the exchange who they won't lose their coverage, but their coverage is going to go up dramatically when these subsidies, and they won't go away completely for everyone, but they won't be as generous as they have been.
Is that a federal decision?
It's a federal decision, okay. Yes.
Was that a bill that was passed, or was that a result of?
It was a result of COVID, and part of COVID relief, federal COVID relief, was an increase in these subsidies, and the federal government has indicated that they are letting those sunset, so those will be going away. So, one of the things that Vermont Medicaid is the most functional, administratively efficient system of healthcare that we have in this state. Vermont Medicaid works. You might have heard, through COVID, there were no redeterminations that were being done, and then that had to unwind, and so Vermont Medicaid has been doing re-enrollment and redeterminations on people's incomes, and there was a huge outcry from people of, I'm losing my Medicaid. They weren't losing their Medicaid, it's just that they had to then reapply for Medicaid, and many of them were not found to be eligible. And that is because when people are on Vermont Medicaid, they love Vermont Medicaid. It is simple, it is efficient, it covers all the services that you need. And we'd really like to get to a point where we can expand the most efficient coverage that we have in this state to larger segments of the population by increasing the poverty level that you would need to qualify under. So H721, when it started, one of the most important things that we'd like to do, and unfortunately this did not make it into the final budget, one of the things we'd like to do is under the ACA, Affordable Care Act, children and youth and young adults under the age of were able to remain on their parents' insurance until the age of 26. Mm-hmm. Well, Dr. Dinosaur, which is for children and pregnant women in Vermont, that's under Medicaid, that ends at 18. So or the income level for Dr. Dinosaur ends at 18. So we're losing this whole segment from 18 years old to 26 years old who do not have the ability to have coverage under their parents, and yet they have fallen off because of income level. And so we really wanted to expand that, and hopefully in the future, in the very near future, we will be able to do that to cover that segment of the population. No one should ever go without health insurance. You just should not do that. And This is a population, 18 to 26-year-olds, we all think that we're invincible at that time of our lives. So what we find is that most of them just go without. And they're also very inexpensive to insure. They're not high utilizers. So we'd like to expand that. We also would like to expand the income level for Dr. Dinosaur for pregnant people. We know that when you have good prenatal care, your health outcomes are better for both you and the baby, and it leads to less expensive care ultimately in the end. Those didn't make it through, but we're going to keep working on that. There was also in this bill a very large, what we were calling a technical analysis, and it was having the Department of Vermont Health Access, DEVA, who administers our Vermont Medicaid program, to really look at what the cost would be if we did large expansions over the course of time for increasing the federal poverty level rate that you have to be at to qualify for Vermont Medicaid. What would that look like? What would that cost? What more people would we be able to insure? Additionally, how much more in federal dollars we would be able to draw down. Every dollar we spend in Vermont Medicaid, we get back more than $1 from the federal government. And also looking at, one of the issues with Medicaid is that the reimbursements sometimes are relatively low, which leads to sort of a cost shift. Whereas, if Medicare and Medicaid are not paying what the cost is to deliver a service, it is left up to the commercial payers to then make up that difference. And we all pay for that when we pay our premiums. When the payers come in talking about raising rates, it's that cost shift is a big driver of that. So we had a lot of analysis over what it would, what level we would have to get to with our rates to sort of stabilize more so that the commercial payers were not having to subsidize the government payers. A lot of the technical analysis made it into the budget. We do have DEVA looking at some of this to let us know in the future how we can expand this. The one thing, and this is very exciting, I get super excited when I talk about this. I absolutely love this program. So this actually did make it into the budget. There is a program called the Medicare Savings Program. Right now, what happens is if you're on Vermont Medicaid, which goes to 138% of federal poverty level, your income, you're on that until 64. The moment you turn 65, happy birthday. You become eligible for Medicare, and you now drop off of traditional Medicaid, and you only qualify for traditional Medicaid if you make under 100% of the poverty level. It's called the Medicare cliff, and it really is a cliff. And so you lose your coverage under Medicaid, and Medicare is wonderful in many regards, but people don't understand there is a cost to Medicare. It does not cover things at 100%. You pay a premium for it. Right now, I think it's at about $185 a month. It comes directly out of your Social Security check. You also you have a deductible, and there is coinsurance. There is no maximum out of pocket. So if one hospitalization with your deductible and 20% coinsurance, you can be looking at tens of thousands of dollars. And so right now, the income level for traditional Medicaid is at 100%. Then there's a program called QIMBY, and that covers to 130, currently 100 or 20%. It covers up to a certain amount. And then there is this great program called QI, and it is 100% federal dollars. It is the federal government paying for people's Medicare premiums at $185 a month. Right now, our levels are set to like 100, 120, I think, and then QI goes up to 130 something. we have expanded that so that this Quimby program will now go up to 150%. So people who were not covered between 100 and 150% of federal poverty level now will be covered under Quimby, which pays for all your Medicare Part B premiums, all of your coinsurance, and all your deductibles. That is terrific. And then by doing that, the federal government then allows us to expand people who qualify under QI, where that is a program, so from 150% to 195% of the federal poverty level, these people will now have their Medicare Part B premiums paid, and they'll also qualify for another federal program called LIS, which covers out-of-pocket expenses for prescription drugs. So that is, it is very small state dollars. All we have to do is cover this one population under what's called Quimby, and then the federal government takes over the rest. And it is expected that I think we have budgeted $5 million to expand the Quimby, but by doing that, we are directly putting over $20 million back into the pockets of Vermonters who are over the age of 65 or disabled, qualify for Medicare. It is a known quantity. You pay $185 a month. It comes out of your Social Security check. If you qualify, it no longer comes out of your check. That is, when you are making $1,200, $1,300 a month, putting almost $200 back into your Social Security check, that makes a huge difference. The expected, with the expansion of the LIST program and this QI program, it's expected to be close to $50 million between prescription drug costs and paying the Medicare benefit. This is just very, very exciting.
That's great. I want to give a chance for either of you, if you have anything to add on the expansion of Medicaid this year.
I think it didn't. 721 got, as Alyssa said, a little bit picked apart and not everything passed. But I think, as I reflect on that and why and how we can kind of take it forward and continue to chip away at expansion and universal health care is doing a lot of education around this. It's clearly a really complex topic. So as great as coverage is, if you're on Medicaid in Vermont, it is a complex web. And I think, if folks understood, what we're trying to do with the expansion of that and maximizing federal funding, as well as streamlining some of the back office efficiencies and administrator burden, there is a strategy to where we can expand this. But I think the first step is really to educate, our colleagues and to lean on folks like we worked a lot with the Office of the Healthcare Advocate, Vermont Legal Aid, to really support us because it's difficult stuff.
Yeah. We've got just under 10 minutes left, and I know there are a couple things that I wanted to ask you, Representative Garofano, about. One being childcare, and then the other one being, well, actually, there are many things that we didn't get to. There's never enough time. But there's the flavored tobacco ban, there's the Emergency Temporary Shelter Program bill, H.879. You can pick from any of those.
Yeah,
Which would you like to
I'm
share?
happy to hit on all three of those quickly. I can. So S18 was the flavored tobacco ban we worked on for many, many, many weeks. Again, this came from our colleagues in the Senate who were really excited about it, and it's an important bill. Unfortunately, it's a really complicated bill. I think I mentioned before we started, it was one of the bills that I heard the most on both sides on. And the bill was and is intending to ban the retail sale of all flavored vapes, all flavored tobacco substitutes with flavor, and flavored e-liquids. And I think, what we were trying to do, and our colleagues in the Senate was trying to do, is to address youth use of these products, which, we try to pass we passed the ban for, under 18 several years ago, and the numbers just keep increasing in schools and under 18. So this bill was trying to address that, to kind of take these off the shelves, not make them available in Vermont anymore. And I think, like I said, we heard from a lot of people from both sides of this, and I think it's a really important bill, but it is a complicated bill, and there are both sides of it. Some of the challenges were the loss of tax revenue, especially this year, was really concerning to people on both sides of the aisle. And the fact that we have flavored alcohol and flavored cannabis that is legal, I think that created some challenges for a lot of people thinking about, okay, does this make sense that we allow the flavored use of tobacco and cannabis, but not vapes? And then I think menthol products was another big issue where this bill was intending to ban the use of all menthol products. So, you know, I do remember that it just did not pass with a very strong majority. So it'll be interesting to see if I know the governor has indicated he's going to veto it. So we'll see in June. But we, you know, we do intend to come back with something stronger next year. I think this is still an important issue, and we do need to address it. So we're not going to drop it if it doesn't, we can't get it through the finish line. And then I'll talk about the emergency temporary shelter program. We had a bill. You know, our chair, I know, as you know, has worked for the last 2 years very closely on housing and the homeless problem in Vermont. And we worked on 879, and that passed the House with overwhelming support. And it kind of stalled in the Senate, but the biggest pieces of it did make it into the budget, which we're really excited about. And again, it's about incremental change and moving forward. So the pieces that made it in, which I'm really excited about, is the task force that is tasked with figuring out how to simplify this process and create an actual program. We do not have a temporary shelter program right now in Vermont. So this task force, which includes stakeholders and state administration officials and advocates, will come together and figure out how do we simplify it. It's, again, very complicated, lots of rules that people who are in really precarious situations have to figure out and how to navigate. So how do we simplify it? How do we make it more efficient? I think we all agree that using hotel rooms to address our homeless problem is not the best use of our dollars. So how do we increase capacity for shelters? How do we increase building for people in that income group that, you know, we need to build for very, very low income individuals, not for, you know, we also need that development too, but I think the investment for very low income. So for the first time in Vermont, I will say we have a 10-year plan that has kind of a roadmap of what we need to do to address the homeless problem and the housing crisis in Vermont. So this has kind of been incremental steps into moving that forward.
And then do you want to talk about the child care?
Yeah, so I'll just say that, you know, we passed this huge landmark child care bill last year, and it's really exciting to see that implemented. We heard from administration officials this year about implementation. The law went into effect in July of 23, and in April of this year, a bigger segment of the population became eligible for what is called Child Care Financial Assistance Program, which is a benefit from this federal government that helps you pay for child care, which we should all have and we should all access. So I encourage all the listeners to go to the Child Development Division website, Act 76, you can Google it, and to see if you qualify. If you have young children that are in early childhood education, and in October will be another bump up for more individuals to qualify. So this is really helping people go to work and not worry about their children, and make sure we have high qualified staff and highly qualified programs. We toured a child care center in St. Albans the last week of the session, and we heard from them that you know, this bill has helped them build out their programming, expand, add slots, pay their staff more. We met a woman who's a director who's been in early childhood education for 30 plus years, and for the first time she has retirement benefits. Imagine that. For the first time in 30 years educating our youngest Vermonters, she has retirement and vacation time and more benefits. So it's really exciting, but ultimately it really helps Vermonters afford to send their kids to a high quality childcare program and not worry about going off to work, and relieves a big stress in a lot of our community members' lives.
That's great. Just a minute or two left if you have any.
I
final-
really
yeah.
wanted to just touch really briefly. People can check out H233, which regulates pharmacy benefit managers. This is work that we've been doing in the legislature for years, and we've been building on this. PBMs, pharmacy benefit managers, they administer the benefits around prescription drugs. And currently they are only required to register with the state. We have set up a process where they now need to be registered and licensed by the state. And this bill also sets up some guardrails around, frankly, what are really predatory business practices. And this is all, trying to get to, when we talk about affordability in healthcare, what is driving affordability in healthcare is prescription drugs.
Right. Awesome. I think we have to end it there, but that's a great place to end it. You all have been so busy this session. There's a lot going on. Thank you all so much for joining us today and chatting about the work that you've been doing.
Thanks for
Thank you for
inviting us.
having us.
Awesome. Great. And thank you
Thanks,
for
Bob.
tuning into Under the Dome. We will see you again in about an hour to chat with some of the senators who've been working on these bills as well. Thanks so much.